So by this point in our course and our time together, you've become quite adept at thinking about specific concrete strategies for transforming health, for creating a better future state tomorrow than exists today in your practice area. And we've also been discussing how crucial it is to mobilize human energy in that process, the commitment, the collaboration, the input, the expertise, the effort, the exertion of the affected community for any given health situation in order to be able to make a successful, sustained transformation. And in our time together this week, we're going to now focus in on expansion. So we talked about the principles and the preconditions for change. We spent quite a bit of time looking at the process for change. And now let's look at how do we expand on success. So we'll be drawing again on the model for sustained transformation and using this as our roadmap to guide our systematic change process from the beginning. So we reviewed an example of a community health center that had a problem. The physicians and nurse practitioners experienced inaccuracy in the vital signs and the setup for procedures. But instead of leaving that situation as simply a problem and a frustration, it became an opportunity for transformation when the clinician at the site worked with the medical director, the chief medical officer, the clinical quality improvement director, and the medical assistants to create a better future state for that clinic. And so today, as we begin to talk about expansion, we're going to do it through the lens of a population health example. So that earlier example was applying the model for sustained transformation principles in a clinical context. This time we're going to look at the same principles and how profoundly applicable they are in a population health context. So our case example is set in Hazara, central Afghanistan. And for those of you familiar with the context of Hazara, this is a region in the highlands that's incredibly mountainous. There's a lot of geographic separation between villages and also a history of extreme gender apartheid with separation of gender-based roles and with a predominance of women caring for children in the primary household and actually being required to stay within the household unless they were chaperoned by a male partner or a father or a brother outside of the home. So that's the context for the case study we'll look at. And I've posted a link to the National Geographic manuscript on Blackboard if you'd like to read more about the social situation. So let's begin our discussion by taking a look at the 4 principles for sustained transformation and the idea of the catalyst and how the catalyst for transformation and change is the driving force in the process. So in just shortly following the fall of the Taliban in Afghanistan, there was an international not-for-profit agency that began to work in Hazara, Afghanistan, with this socially marginalized ethnic group. And there was a high priority in the organization to focus on maternal health and particularly maternal mortality. The best estimates at the time suggested that the maternal mortality ratio in Hazara was around 21,000 per 100,000 live births. And by comparison, maternal mortality in places like the United States is 20, places like Sweden is 1, and Kenya is 413. So a profoundly high burden of maternal death in this region of Afghanistan. And that's partly due to the geographic isolation of the region, in part due to significant gender apartheid practices that existed within the society. So this agency from the outside came in and began to try to take inventory and measure the burden of maternal mortality. So this was the catalyst. Can we describe and measure mortality in this context? And what happened was the agency was building their intervention work on these 4 principles of sustained transformation. So when they began to gather data about maternal death, it was done so in a very atypical way. Instead of using technical expertise from the outside to do standard survey methodology, what happened was the inventory was focused in several geographic regions and led by an Afghan obstetrician who was female. So she went into the homes of women, and culturally that was acceptable because she was female. She could go in, and instead of just simply gathering health outcome data on mortality, she began to ask women to tell her their birth narratives and what it was like to give birth, what their experiences were, what the outcome was for that pregnancy. And so as she began to listen to these narratives, some key themes around drivers of maternal and neonatal deaths emerged. And what happened was, in the context of those narratives, the obstetrician began to provide some specific health messages that were customized to that woman's birthing experience. So the health education wasn't an abstraction, and it wasn't divorced from that woman's life experience. She gave them some tips and guidance about how to provide even better care for themselves and their infants in a future situation that was similar to the one that they had experienced. And as this obstetrician began to gather more and more data, she realized these similar themes emerging between women's birth experiences. It would be helpful to build on the strengths and successes that the women had, because historically women were not permitted to gather together. They were only allowed to go out when chaperoned by a male family member or attendant. So women weren't gathering. And this outside-in agency suggested, why don't we bring the women together to talk and share their birth narrative so they can see the commonality of their experiences, the commonalities of challenges and successes. But because there's a strong history of gender apartheid, it wasn't possible to ask the women to come to a gathering because they weren't historically, didn't have mobility socially. They needed a male chaperone. And since the focus of the story was birthing experiences, and culturally that was not a discussion that men were part of outside of their family experience, it presented sort of an interesting conundrum of sorts about how to bring the women together to tell their stories and yet operate within the confines and the parameters of the cultural context. And so what they did is they built on existing cultural norms by asking the husbands to, quote, give permission for their spouses to attend this women's only workshop, but to be accompanied by the husband's mother. So now you have a female-female alliance between the wife, partner, and the mother-in-law. And so with this husband-based permission that was the cultural norm, the wife was now able to come to this woman's only workshop. And as the women came together, the obstetrician who had gathered the data and given narrative-based health education was a key facilitator. And she had not only technical health expertise, but was also partnering with this international NGO as an outside-in partner. So you had a partnership between the women, their husbands, and the mother-in-laws, but also between the obstetrician and the NGO to design these women-only workshops. So what happened was, as the women came together, they began to share their life experience. They shared data and information about birthing children. And as they engaged in that storytelling, they themselves identified common themes and challenges they had in caring for their children and having their children survive. So what happened was the international NGO had an agenda of maternal mortality. But in the process of talking about that with the women, the NGO's main objective became secondary to the community's main objective. And what happened was, as these women gathered together, they began to say, we need to be able to have basic literacy skills. That's what they identified as a key need among themselves. And there was one member of these gatherings who had an 8th grade education, which was extremely high in this particular region. And this person with the 8th grade education said, you know what, we need to begin to offer the literacy to women, and I actually have skills to help them. So they began to work in one village with an imam at a mosque. And the NGO provided some technical curriculum building expertise around literacy. And so they started to identify that they have mosques that are available. They have this woman with an 8th grade education. They have the international not-for-profit who has some technical expertise. So out of those discussions, they identified the priorities of having home health literacy-based training. So the literacy that the women wanted and were requesting was based on how to care for their young children and their pregnancy. And as they identified those priorities, the goal then became, let's have this literacy-based workshop. They began to develop curriculum in partnership with the NGO and the woman with the 8th grade education. And they set up action steps to have this mosque-based female literacy program. As it went on and continued, they developed increasing strength locally so that the curriculum progressively evolved to address the women's needs and interests. So with that overview of how a literacy, health-based literacy began in Hazara, Afghanistan, we've worked through the 4 principles of sustained change. You saw how each step of the process of change was encountered. I'd like to give you a second lens for thinking about action and how we create action. You can use 5 W's when you're creating your action plan. You can say who will do what, when, where, and with what. And these 5 W's can then be a guide for the working plan of your DNP project. And as we saw in the Afghanistan example, who will do became first the obstetrician gathering information on women's birth experiences, but that quickly became who will give and support the women in developing literacy skills and home-based health skills. That was the woman with an 8th grade education. What will she do? She'll provide that literacy in partnership with the obstetrician and NGO, who will give the technical expertise on maternal care and curriculum design. But the woman with the 8th grade education who's local to the community, she is going to be delivering the what of the literacy training. When is it going to happen, and where is occurring at the local mosque, and with what resources? There were actually no significant financial inputs externally for this literacy program. Some basic materials were developed in partnership with the woman and the NGO. And so that's how they began to create a work plan. And ultimately, we'll see in our next talk together how that was spread beyond the borders of the small one mosque literacy program. So come back soon and we'll look at that together.